Let's take a quick look at hypertension and go through some of the main antihypertensive drugs. Firstly, let's just recap on what blood pressure is. Blood pressure is the amount of force that the blood places upon the walls of your blood vessels. So when your heart contracts and pushes blood out, that blood has some sort of force behind it. And as it comes out, it's going to put some form of pressure on the walls of your arteries. Now, you measure this with a cuff, and you'll place that cuff predominantly around the brachial artery, and that's a branch of the aorta. And as the blood comes through, it puts some pressure on it. Now, there's two predominant phases. The systolic phase, this is when the heart contracts and pushes the blood. So that's when the blood is at its highest pressure. And there's the diastolic phase when the heart relaxes. And again, blood's being pushed upon the walls because of the recoil of the aorta. And this is the diastolic value. So if you were to take consistent measurements from a patient when the patient's at rest, what is considered a normal blood pressure? Well, a normal blood pressure is a systolic value of below 120 and a diastolic value below 80 millimeters of mercury. Okay? What if you have consistent measurements above this? Well, if you have measurements between 120 to 129 for the 139, for the systolic, and measurements from 80 to 89 for the diastolic, this is recognized as being pre-hypertension. So not yet considered hypertension, but it demonstrates that this patient may potentially develop hypertension at some point down the track. What if a patient, you get consistent measurements of 140 and above and 90 and above? 140 and above for the systolic, 90 and above for the diastolic. Again, it's in millimeters of mercury. This is recognized as hypertension. So today when we're talking about hypertension, we're talking about consistent measurements of blood pressure taken from the patient, when they're at rest, and these measurements are above 140 and above 90 millimeters of mercury. All right. What alters this? So how do you get 120 over 80, and how does this change to anything above? Well, we need to talk about blood pressure in itself and talk about what factors contribute to blood pressure. So, there's an equation that tells you what are the contributing factors. Blood pressure is equivalent to cardiac output. Remember what cardiac output is? Cardiac output is the volume of blood that's being injected by the heart per minute multiplied by systemic vascular resistance. Systemic vascular resistance. Now, systemic vascular resistance is also called peripheral vascular resistance or total peripheral resistance. This is the resistance that blood encounters through blood vessels, and basically has to do with the diameter of a blood vessel and the length of a blood vessel. Okay, blood pressure is equivalent to cardiac output, how much blood's being pumped out per minute, times systemic vascular resistance, the resistance that the blood faces as it moves through the lumen of those blood vessels. Let's first focus on cardiac output. What defines cardiac output? So what are the contributing factors for this? Well, if it's the volume of blood being pumped out per minute, then the contributing factors would be stroke volume. Do you remember what stroke volume is? That's the volume of blood being pumped out per contraction. And it would also be heart rate, which is how many times does the heart beat per minute. So cardiac output is stroke volume times heart rate. Stroke volume is about 70 mils. So every time that left ventricle contracts, pushes out about 70 mils of blood. It does this about 70 times in a minute, 75-ish times. So 70 mils times 70 to 75 times gives you approximately 5 litres, which means cardiac output is approximately 5 litres. All right, systemic vascular resistance. This is how I like to think about it. If you have a blood vessel, you know blood vessels are hollow. So you've got a blood vessel and it has quite a large lumen. So it's quite patent, quite open. Compare that to a blood vessel that's contracted and has a smaller lumen. Well, when blood moves through this blood vessel, which one is going to experience greater resistance? Well, it's going to be harder for the blood to move through this one here because it's narrower, okay? Which means that this blood vessel has low systemic vascular resistance and this blood vessel has high systemic vascular resistance, which means that when blood vessels constrict, it results in systemic vascular resistance. And what that means is blood needs to pump harder to get through, which means increased systemic vascular resistance results in increased blood pressure. In actual fact, if you look at all of these factors here and see how they contribute to altering blood pressure, if you increase cardiac output, you will ultimately increase blood pressure. If you increase systemic vascular resistance, you'll increase blood pressure. If you increase heart rate, you'll increase blood pressure. If you increase stroke volume, you'll increase blood pressure as well. Now, what are some of the factors that affect stroke volume? So the amount of blood that's pumped out per contraction. Well, that's easy. That has to do with blood volume. And what else? Well, that blood volume needs to get out, so the heart needs to contract, so contractility. All right, well, if we were to look at the major factors affecting blood pressure, you would say that they are blood volume, you would say they are contractility, you would say that they are heart rate, you would say that they are systemic vascular resistance. Which means, now, somebody has hypertension, we want to treat their hypertension, we need to give them antihypertensive drugs. What do these drugs do? They will either try and reduce systemic vascular resistance by dilating blood vessels. They'll try to reduce heart rate by either stopping the sympathetic nervous innervation, well, that's predominantly the way that they'll do it. Contractility, what causes muscle to contract? Calcium influx causes muscle to contract, so by reducing calcium. Or by reducing blood volume, and they can do this by inhibiting the renin-angiotensin-aldosterone system, which you know when it gets stimulated, increases blood volume, or by giving a patient some form of diuretic. Diuretic increases the urine output, again reducing blood volume. So these are the major factors that contribute to blood pressure, and these are the factors that antihypertensive medications play around with to alter blood pressure. Now, there's 3 different types of hypertension. Primary hypertension. Primary hypertension, also known as essential hypertension, we don't necessarily know what the cause is all the time. There's secondary hypertension, which means that the hypertension is secondary to some other underlying cause, which means if you treat the underlying cause, the hypertension disappears. And you also have malignant hypertension, which is a rapid onset of hypertension, which is associated with organ damage or organ failure. Today we're just going to focus on essential or primary hypertension and some of the common meds used for that. So, I'm just going to use this little area here to write down the common types of antihypertensive drugs, and we'll talk about how they have their effect in this system. What I'll do is just rewrite that over here. Cardiac output times systemic vascular resistance. Okay. Let's have a look at some of the antihypertensive medications. So first I want to talk about are what we call the beta blockers. Now, beta blockers. You should know that beta, now it can be written like that or it can be written as BETA. Beta blockers. So your sympathetic nervous system will stimulate certain receptors. So remember that if you look at a sympathetic neuron, that the sympathetic neuron that innervates the target organ, let's just say the heart for example, has to release a neurotransmitter at the synapse. What's the neurotransmitter released at all sympathetic neurons at the target organ, at the effector organ? It will either be adrenaline or noradrenaline, which means adrenaline or noradrenaline need to bind to specific adrenaline or noradrenaline receptors called adrenergic receptors. Remember, you've got alpha 1, alpha 2, beta 1, beta 2, beta 3 adrenergic receptors. What are the receptors specifically located on the heart? They are the beta 1 receptors, which means that for beta blockers, you can have what we call selective beta 1 beta blockers. So I'll just write selective. Selective beta 1. And examples of selective beta 1 are atenolol, and also metoprolol. You can see that the beta blockers are the LOL drugs. Now these are selective, which means they will specifically bind to beta 1 receptors on the heart. Okay? Which means what? Well, if you've got the sympathetic neuron and it's releasing adrenaline, if that adrenaline or noradrenaline binds to this beta 1 specific receptor, what happens to the heart? Well, the heart rate increases and the contractility of the heart increases if adrenaline or noradrenaline binds to it and stimulates it. Beta blockers such as atenolol and metoprolol, they will bind to this receptor and antagonize it, which means it does not get stimulated, which means heart rate decreases. If you decrease heart rate, you decrease blood pressure, and contractility decreases, decreased contractility, decreased blood pressure. These are the selective beta blockers. There's non-selective beta blockers as well. For example, I'll write it over here. The non-selective beta blockers. And the non-selective are propranolol, again, the LOL medications. And propranolol is non-specific, which means, what does that mean? Well, okay, let's look at the beta receptors. I said that you've got beta 1, beta 2, beta 3. And I said beta 1 you find at the heart. Where else do you find beta 1 receptors? Also find it at the kidneys. What about beta 2? Well, you can find beta 2 on vascular smooth muscle. You can find beta 2 at skeletal muscle. You can find beta 2 at the bronchioles of the lungs as well. What about beta 3? You find beta 3 in fat cells, basically. Now, when we look at the selective beta blockers, they bind specifically to beta 1 and inhibit the effect of the sympathetic nervous system at the heart and also at the kidneys, which means less renin is released. Remember that. What about the non-selective? Well, that means they block all three. Now, they block the heart, that's fine, same effect as beta 1. Blocking fat cells, who cares? Beta 2, well, what's the major adverse effect that you'll find here? If it's blocking activation from the sympathetic nervous system at the lungs, remember what happens. Stimulate your fight or fright system, flight or fright, or fight. If you stimulate that system, what happens? The bronchioles of your airways dilate. You get more air in, more air out. That's good. You can have more oxygen to run away. But if you block that, what happens? The opposite, it constricts. So it's not wise to give non-selective beta blockers to patients with already existing reversible airway diseases such as chronic obstructive pulmonary disease, so emphysema and asthma. Okay, let's move on. So they're the beta blockers. What else can we look at? Let's look at ACE inhibitors. Okay, firstly, what's ACE? ACE is angiotensin converting enzyme. You need to go back and watch the movie or the video on the renin-angiotensin-aldosterone system, or do some reading up. And you'll realize that before angiotensin 1 can be converted into angiotensin 2, an enzyme needs to come into play in order for this to occur. That enzyme is angiotensin converting enzyme. Now, what's important about this whole process here? Well, once we make angiotensin 2 has a number of different activities in the body. First of all, it's a vasoconstrictor. A potent vasoconstrictor, which means if you constrict blood vessels, what are you doing? You're increasing systemic vascular resistance, increasing blood pressure. What else does angiotensin 2 do? It results in the release of aldosterone. Why is that important? Aldosterone promotes sodium reabsorption at the kidneys back into the blood. More sodium into the blood, more water into the blood, more blood volume, increased blood volume, increased blood pressure. What else? Angiotensin 2 stimulates the release of antidiuretic hormone. What does that do? It tells the kidneys to hold on to water again. Holding on to water increases blood volume, increases blood pressure. So angiotensin 2 is released into the body to increase blood volume and blood pressure. Therefore, if you inhibit its production via ACE inhibitors, then what happens is you reduce blood pressure. A common medication is enalapril. Enalapril is a common ACE inhibitor. Okay, let's move on. I'll write that over here so I've got more room. Okay, let's look at the angiotensin 2 receptor antagonists. So this doesn't need too much explanation because I just spoke about it. You can use ACE inhibitors to stop angiotensin 1 into creating angiotensin 2, or you can use angiotensin 2 receptor antagonists, which means it stops the ability of angiotensin 2 to binding to its receptors, which means it stops vasoconstriction, it stops aldosterone release, stops ADH release, and stops or reduces blood pressure. These are the sartans. And a common one is candesartan. So as a recap, beta blockers are the LOLs, ACE inhibitors are the prils, angiotensin 2 receptor antagonists are the sartans. Let's keep going. What else do we have? We've got calcium channel blockers. Now, remember what calcium does. Calcium is one of the most abundant extracellular cations, okay? So that means it's positively charged, as you can see here, and it's located outside of the cell. When it enters the cell, it can do a number of different things. It can act as a secondary messenger, so it can tell certain things to happen inside the cell, or it can tell muscles to contract. So if you block calcium from entering myocardium, heart muscle cell, you can reduce its ability to contract. That's one thing. The other thing is that certain cells of the heart, such as the nodal cells, sinoatrial node, atrioventricular node, in order for them to depolarize, they require calcium to come in, which means these calcium channel antagonists or calcium channel blockers, what they can do is they can inhibit or reduce the depolarization event of the AV and SA node, slowing the heart rate down and reducing its contraction. There's three major types of these calcium channel blockers. First one is nifedipine. or the nifedipine-like drugs. All right, these drugs do a couple of different things. Firstly, you need to be aware that there's not just one type of calcium channel. There's many different types, and they're located in many different parts of the body. And in actual fact, one organ may have many different types of calcium channels, which means that these different types of calcium channels have certain specificity and may or will have different effects. So for example, nifedipine, you'll find, is predominantly found on the vascular smooth muscle. Nifedipine, I should say, acts at calcium channels at the vascular smooth muscle. Blocking calcium's effect, reducing vasoconstriction, resulting in vasodilation, reducing systemic vascular resistance, reducing blood pressure. It also seems to have an effect as a angiotensin II, aldosterone, as an aldosterone receptor antagonist as well. What do I say that means? Well, if you stop aldosterone from having its effect, you stop sodium reabsorption, stopping water reabsorption, reducing blood volume, reducing blood pressure. What other types of calcium channel blockers do we have? We've got veramapil, where do these particular drugs have their effects? Well, they tend to work on calcium channels, so block calcium channels at the nodes, so SA node, AV node, so nodal blockers, and what you'd refer to as conductive tissue. So veramapil blocks the sodium channels at the nodes and the conductive tissue, reducing arrhythmias. So this is a common anti-arrhythmia medication as well. Okay, what's the last one I want to talk about? Diltiazem. Where does diltiazem tend to have its effect? At the coronary vasculature. All right, last thing I want to talk about, don't have too much room here, is, so I'm going to have to get rid of the beta blockers, other diuretics. Now, the diuretics act at the kidneys, specifically at the nephrons, and predominantly reduce sodium reabsorption, which means increases the amount of sodium that gets peed out, which means increases the amount of water that follows, increasing the volume that you pee out, reducing blood volume, reducing blood pressure. The most common sort of diuretic that would be used as an antihypertensive medication are the thiazides. Okay? Now, why would we use, now, where do thiazides work, first of all? At the distal convoluted tubule. Why wouldn't we use a loop diuretic, for example, acting at the loop of Henle? Well, they're very potent, very powerful, and they're short-lasting. So you'll find that the thiazides are actually longer-lasting and tend to be more effective as antihypertensive medications. They're commonly used in conjunction with one of these other medications. Now, what does this thiazide do? At the distal convoluted tubule, it stops sodium from being reabsorbed. So if you look at the nephron, here at the distal convoluted tubule, you've got cells in the walls here. It stops sodium from being reabsorbed back into the body, which means sodium stays in this tubule, which means water stays in this tubule, which means what gets peed out? Sodium and water, reducing blood volume. Now, all diuretics that act prior to this area here result in potassium being peed out as well, which means that it's not a potassium sparing diuretic, which means that potassium may also be peed out as well. So you need to be careful with the potassium levels of the patient who takes this medication. So these are the major drugs. This is hypertension. I hope that it all made sense. Best of luck.